You know, we often hear about the big headline-grabbing health issues, but what about the ones sort of lurking in the background that can seriously impact people's lives?
hmm
Consider lymphedema. It might not be a household name, but if it's left unmanaged, it can cause really significant limb swelling and, well, dramatically reduce someone's quality of life. That's what we're diving deep into today.
Absolutely. And we're focusing specifically on the non-operative ways to manage lymphedema, drawing from the really comprehensive information in Rutherford's Vascular Surgery and Endovascular Therapy 10th edition.
Okay.
At its core, lymphedema happens when there's a kind of traffic jam in your body's fluid disposal system. Basically, more lymph fluid is produced than the lymphatic system can handle, leading to a buildup of this protein-rich fluid in the tissues.
Okay, so it's like the plumbing gets backed up, essentially. Now, the book mentions primary and secondary lymphedema. What's the quick way to tell them apart?
Yeah, good distinction. Think of it this way. Primary lymphedema is often something you're born with, maybe a developmental quirk in the lymphatic system itself.
Ah, okay.
Secondary lymphedema, which is actually much more common, is triggered by something else. That could be surgery, radiation for cancer, an injury, or even chronic vein problems. Lots of potential causes.
Right, so our focus today isn't really on the operating room or figuring out exactly what caused it for every person. Instead, we're zeroing in on how to manage lymphedema without surgery.
Exactly.
Since there's no cure right now, the name of the game is reducing that swelling and warding off potential
Uh,
complications.
Precisely. We'll be exploring a whole range of strategies, from simple preventative steps and specialized therapies all the way to the vital role of looking after yourself day to day.
Okay, let's start there then. Let's talk about who needs to be extra vigilant. Who are the folks who are more at risk of developing lymphedema?
Identifying those at higher risk is definitely key. Globally, particularly in less developed countries, a parasitic infection called Wuchereria bancrofti is a major culprit behind lymphedema.
Oh, okay.
Yeah, and large-scale drug administration programs using a combination of diethylcarbamazine plus ivermectin have actually been very successful in reducing lymphatic filariasis, which is what it's called, in those areas.
That's huge progress.
It really is. Yeah.
Interestingly, the research showed that giving higher doses of another drug, albendazole, didn't improve things and actually caused more side effects. So the combo was key.
That's a really important perspective on a global scale. Now, bringing it closer to home, say in developed countries, who should be particularly aware?
Here, we primarily focus on two main groups. First, people undergoing cancer treatment, especially if it involves radiation that includes lymph node areas or the surgical removal of lymph nodes.
Right.
Second, individuals who experience repeated bouts of cellulitis, that bacterial skin infection.
Okay, it makes sense that messing with the lymph nodes during cancer treatment could cause problems.
Yeah.
The book talks about being more careful with techniques like sentinel lymph node biopsies for breast cancer and melanoma. Has that made a difference? Oh, absolutely. Those more precise surgical approaches have been a real game changer.
Really?
Yeah. For instance, the move towards sentinel lymph node biopsy in breast cancer care. It's led to a dramatic drop, something like 80% in the incidence of lymphedema.
80%, that's incredible.
It's a huge win. The text also points out, and this is important, that obesity is a significant risk factor for lymphedema after breast cancer treatment, along with the extent of the surgery and radiation, if healing is delayed, and even if the tumor itself blocks lymphatic drainage. Multiple factors.
And what about this connection between recurrent cellulitis and lymphedema? It sounds like it could go both ways, like a vicious cycle.
It can indeed be a bit of a cycle, yeah. Repeated cellulitis infections can damage the lymphatic system over time, potentially leading to lymphedema.
Okay.
But the reverse is also true if you already have lymphedema. That stagnant fluid creates a perfect breeding ground for bacteria, making you more prone to cellulitis.
Ah, I see.
So yeah, sometimes it's tricky to figure out which came first. For people in this situation, doctors often consider preventative antibiotics and maybe antifungal creams if there are fungal infections involved too.
So for someone who knows they're at risk, maybe after a cancer treatment, what are some everyday things they can do to try and keep lymphedema at bay or, stop it from getting worse?
Yeah, there are several really important preventative steps highlighted in the text. These include being meticulous about daily skin care, really avoiding any breaks that could let infection in, being extra careful to avoid bumps and bruises on the at-risk limb, elevating the limb whenever possible to help with drainage.
Makes sense.
Dietary adjustments like cutting back on salt and making sure you're getting enough protein are also recommended, plus wearing properly fitted compression stockings.
Okay.
And maybe surprisingly, given past advice, staying active is really important.
Exercise. I was just thinking, I think there used to be this idea that you should really protect that limb and not use it too much, almost baby it.
You're spot on. There absolutely used to be a fear that overdoing it with an at-risk limb could actually trigger lymphedema.
Right.
However, research, specifically randomized controlled trials, have actually shown the opposite. Gentle, gradual resistance training is not only safe for breast cancer survivors, but might even offer some protection.
Wow, that's a major shift.
It really is. It's a real shift in how we think about it.
Yeah.
And there's an ongoing study, the Lymphprint study, which is interesting because it's looking at how common chronic swelling is around the world, highlighting that, we still have a lot to learn globally.
Okay, so what kind of exercise routines are we talking about here? Is anything specific?
The book suggests a mix. There are what are called lymphedema remedial exercises. These are active, sort of repetitive, gentle movements of the affected area.
Okay.
And you combine those with your regular aerobic exercise, some strength training, and flexibility work. While there's less specific research on things like Pilates and yoga for lymphedema, they might also be beneficial. The key takeaway, though, is to avoid extreme heat or cold, which could potentially stress the tissues.
Right, okay. Good advice. Now let's say lymphedema has already developed. The book mentions complex decongestive therapy, or CDT. That sounds like a pretty involved process.
It is indeed. CDT is considered the gold standard for managing more established lymphedema, specifically stages 2 and 3. It was developed in Europe, came to the U.S. in the early 90s, and its effectiveness has been, pretty well documented worldwide.
Okay, and what does it involve?
It has 4 main parts that really work best when used together. Manual lymphatic drainage, which we can call MLD, compression bandaging, compression garments, and sometimes pneumatic compression devices.
4 components, and it's not just a one-time treatment, right? I think you mentioned phases.
Exactly. CDT has 2 distinct phases. The first phase, called the initial or reductive phase, phase I, is all about significantly reducing the swelling in the affected limb and taking really good care of the skin. This is usually an intensive program, can last several weeks.
Okay, intensive.
Right after that comes the second phase, the maintenance phase, phase 2. And the goal here is for the individual to take over and manage their condition long term, basically to maintain the improvements they saw in phase I.
This sounds like it requires some specialized knowledge. I mean, do therapists need specific training for this?
Oh, absolutely.
Yeah.
CDT definitely needs therapists who are specifically trained in techniques like manual lymphatic drainage and the very precise way of applying these multi-layered compression bandages.
Right.
In the U.S., there's a certification process through the Lymphology Association of North America, or LANA, that helps ensure therapists have the right skills.
Okay, LANA certification.
Yeah. And while phase I can make a big difference in reducing swelling, keeping that progress going in the long run really depends on the patient sticking to their home-based program in phase 2.
That makes sense. Self-management is key.
Totally. Sometimes, though, insurance coverage for that intensive phase can be tricky. And for milder cases, there might be alternative programs you can do at home. Interestingly, there was a small pilot study looking at combining hyperbaric oxygen therapy, HBO, with CDT.
Oh.
Yeah, and they saw some promising changes in how the tissue fluids were behaving using something called bioimpedance spectroscopy. But we definitely need more research there before making big claims.
Okay, still early days on that. Let's zoom in on one of those key components, manual lymphatic drainage, or MLD. What exactly does that involve? It sounds gentle.
It is.
Yeah.
MLD, which was developed by Emil Vauder, is a gentle, hands-on technique. It uses light pressure on the skin to encourage the movement of fluid through the superficial lymphatic vessels. Think of it as trying to gently encourage a slow-moving stream to flow more freely, helping to relieve congestion and reduce any hardening of the tissues that can happen.
The book mentioned dividing the trunk into different areas. What's the idea behind that?
Yeah, that's part of the technique. Before starting MLD on the limb, the therapist will often divide the trunk into 6 regions that correspond to different groups of lymph nodes.
Why?
Well, the treatment usually starts by gently massaging an area of the body that's not affected, but is close to the swollen limb. This helps to sort of prepare the healthy lymphatic system to receive the excess fluid and redirect it towards those functioning drainage pathways, clearing the way, so to speak.
Ah, I see. Preparing the exit routes. So MLD is particularly helpful for certain parts of the body.
Yes, exactly. MLD is really valuable for treating areas where it's hard to get sustained compression, like the face, the chest or breast area, the genital area, and the trunk itself.
Makes sense.
Now, while the evidence suggests that combining MLD with compression bandages does help improve lymphedema, the book points out that MLD on its own isn't really shown to reduce limb volume significantly, except perhaps in easing symptoms for people receiving palliative care, where comfort is the main goal. There's also a mention of a device called Lymphedema that can assist with standard manual massage techniques.
Interesting.
Yeah, and one study found that MLD didn't lead to any greater reduction in arm size compared to CDT as a whole, though both groups saw similar improvements in other symptoms like pain or heaviness. There was even some discussion about whether preventative MLD might be helpful for breast cancer patients, but the research is still ongoing there.
Okay, so MLD is one piece, often combined. Moving on to compression, the text talks about both bandaging and garments. What's the main difference in how they're used, especially in those two phases of CDT?
Right, compression is huge. Compression bandaging, specifically using elastic bandages that have a low stretch, sometimes called short stretch bandages, is the main workhorse in phase I of CDT.
Okay, phase one workhorse.
Exactly. This involves wrapping the limb in multiple layers. You usually start with a soft, tubular bandage underneath, then layers of padding, sometimes special bandages for individual fingers or toes, and finally, the short stretch bandages themselves.
Wow, multiple layers.
Yeah, and these bandages create what's like an internal pump when you move. They have low pressure when your muscles are relaxed, but a high pressure when your muscles contract against them. That helps to push the lymph fluid along.
Clever.
Specialist applied inelastic multi-component compression, or ICM, bandages are considered the standard for this phase. But we're also seeing more self-applied adjustable compression wraps, ACWs, emerging. They're mainly used for the maintenance phase, but potentially could be used for initial treatment too.
And is the way you put on these bandages really important, like the technique?
Oh, absolutely crucial. Applying them correctly with low to moderate tension and making sure there are more layers further down the limb distally is key to creating an effective pressure gradient that pushes fluid upwards.
Got it. Gradient is key.
Yep. During phase I, these low-stretch wraps are typically worn around the clock, 24/7.
Wow.
Then, in phase II, people usually switch to compression garments during the day and often continue using the wraps or an alternative non-elastic device at night. Some more severe cases might need long-term bandaging at home.
Okay.
The book also mentions the historical idea of using heat along with compression, but that's now considered somewhat debatable, not standard practice.
Right. Then we have compression garments. When do people start using those, and what should they know when choosing them?
Compression garments come into play in all stages of lymphedema management, sometimes even as a preventative measure for those at risk. Wearing properly fitted, graduated elastic compression garments every single day is essential for keeping the limb size stable once it's reduced.
Graduated, meaning?
Meaning they are designed to have a higher pressure at the lower part of the limb, say, the ankle or wrist, and the pressure gradually decreases as you go up the limb. This helps to support the flow of lymph upwards. Typically, they provide a pressure of around 20 to 50 millimeters of mercury, millimeter Hg. Generally, the strongest compression you can comfortably tolerate is thought to be the most beneficial, but that needs to be assessed individually.
Are there any things people should be careful about when it comes to compression garments, like pitfalls to avoid?
Yes, definitely. Garments that are too tight or don't fit correctly can actually make the swelling worse or cause other problems like skin breakdown. Getting the right fit is absolutely crucial for them to be effective in reducing swelling.
Fit is everything.
It really is. They come in lots of different sizes, compression levels, and materials. Sometimes custom-made stockings or sleeves are needed if there's a lot of swelling or an unusual limb shape. And importantly, these garments lose their elasticity over time, so they should be replaced every 3 to 6 months.
Good to know. Are there times you shouldn't use them?
Yes, there are some situations, contraindications. These include if you have significant arterial insufficiency, poor blood flow in the arteries, also acute heart failure, severe limb shape distortion, deep skin folds where moisture can get trapped, extensive open wounds or ulceration, severe nerve damage, or if there's a lot of fluid leaking from the skin called lymphoria.
Okay, important list. What about wearing them during exercise?
Yeah, that's a common question.
Yeah.
The research isn't conclusive for or against wearing compression garments during exercise. It seems to be quite individualized. Some people find it helpful, others don't. Probably best to discuss that with your therapist and see what works best for you personally.
And what about how long the stocking should be? Does it need to go all the way up?
Generally, the stocking or sleeve should cover the entire area that's swollen. However, you also have to consider the person's comfort And frankly, if they can actually put on and take off longer stockings. Knee-high or thigh-high stockings that also have some support higher up, like a silicone band or waist attachment, are often better tolerated than full-length pantyhose-style ones,
Yeah.
especially for lower limbs.
Okay.
It's really important for the person to be involved in choosing a garment that fits well and doesn't roll down or bunch up, because that can create a tourniquet effect. And regular skin checks under the garment are crucial to make sure there's no irritation or breakdown.
Makes sense. The text also briefly mentions non-elastic compression. How does that compare to the elastic garments we've been talking about?
Right, those are things like commercial non-elastic support devices. Brand names you might hear are Circade or Reed Sleeve. They offer alternatives to wearing elastic bandages, particularly at night.
How do they work?
They usually use Velcro straps or sometimes foam with canvas and Velcro to provide compression. These can be really helpful for people who find it difficult to manage the more complex wrapping techniques, maybe due to arthritis or dexterity issues.
Good option for some then.
Definitely. However, the book notes that we don't have as much rigorous research, like large prospective trials, specifically testing how well they work compared to other methods. Anecdotally, they seem helpful.
Okay. Another mechanical approach discussed is sequential pneumatic compression, or IPC. Sounds technical. How does that work?
Yeah, IPC involves using an external pump that inflates and deflates a multi-chambered sleeve or boot that goes around the affected limb. It does this in a sequential manner, usually starting inflation further down the limb and moving upwards.
Like a wave of pressure.
Exactly. One study mentioned actually showed significant reductions in limb volume, even a decrease in BMI, improved quality of life, and potential cost savings with IPC use. It can be a good option, especially for people who have trouble with the self-care aspects of bandaging or MLD. It provides that external force to help move the stagnant fluid.
What's actually happening inside the body when this intermittent pressure is applied? What's the mechanism?
Well, the rhythmic squeezing and releasing action creates beneficial changes, hematologic, hemodynamic, endothelial, the book says. Basically, good things for blood flow, fluid dynamics, and the health of the vessel lining.
Okay.
It essentially mimics the natural muscle pump action that normally helps push lymph fluid along. IPC also helps reduce swelling by decreasing the amount of fluid that leaks out of the tiny blood vessels, the capillaries, and by physically squeezing the excess fluid out of the swollen tissues.
Does it work equally well for everyone?
How well it works can depend on the specific device being used and the individual's clinical situation. A study by Bergen and colleagues compared different pump types and concluded that multi-compartment pumps that create a pressure gradient, higher pressure distally, lower proximally, were generally the most effective.
Okay, gradient again.
Yeah.
Are there specific pressure settings or like how long you use it that are considered best for IPC?
That's still something that researchers are looking into, honestly. There's some suggestion that pressures above, say, 59 millimeter at Hg might potentially harm the delicate lymph vessels themselves, but it's not definitive. The ideal pressure, how often you should use the pump, and for how long each session, well, it isn't really set in stone yet. Studies have used a wide range of setting sessions, anywhere from 90 minutes to 6 hours, treatments lasting from days to weeks. Typically, after an IPC session, a low-stretch elastic sleeve or bandage is put on to help maintain the reduction in swelling achieved by the pump.
Right, maintain the gains.
Exactly. There's a theory that ITC might even help to create little channels in the tissues that aid in fluid drainage long-term. For lower lymphedema, long-term higher-pressure IPC seems to be generally safe based on current data.
And are there any situations where someone should not use IPC? Any contraindications?
Yes, definitely. These include having an active malignancy cancer in the affected limb or nearby regions where the fluid would drain. Also, any active infection in the limb like cellulitis. A known blood clot, like deep vein thrombosis, DVT, is another. And usually being on anticoagulation or blood thinners is a relative contraindication needing careful consideration.
Okay.
Interestingly, while some studies haven't found that adding IPC to standard treatment significantly helps reduce volume further in breast cancer-related lymphedema, it has been shown to improve symptoms, reduce episodes of cellulitis, and help heal ulcers in people with lower extremity lymphedema. So it can be a valuable supplemental therapy, especially for the legs.
Got it. The chapter then discusses the general pressure level for compression therapies overall. What are the key things to keep in mind here across the different methods?
Okay, pulling it together on pressure. The text suggests that if there's no problem with blood flow in the arteries, no significant peripheral arterial disease, a maximum sustained pressure of maybe 60 to 70 millimeter Hg is generally considered safe for lymphedema treatment.
Okay, 60-70 max sustained.
For lower limb compression stockings, you can find various strengths available, usually from 20 up to 60 millimeter Hg. For persistent chronic lower limb lymphedema, a pressure of 30 to 40 millimeter Hg is often recommended. But lower pressures, maybe 20 to 30 millimeter Hg or even less, might be better for people with other health issues like heart failure or mild arterial disease.
And for arms?
For upper limb garments, the typical pressure is often around 20 to 30 millimeter Hg, though again, other options are available depending on the stage of lymphedema and how firm the tissue feels.
Right.
Some studies, particularly with sequential pneumatic compression, IPC, have shown that using higher pressures, even up to 90 or 100 millimeter Hg intermittently, can effectively reduce limb size and volume.
Okay.
And while IPC is well established for preventing blood clots and managing post-thrombotic syndrome, the ideal pressure specifically for treating lymphedema is, as we said, still being fine-tuned. There's some evidence suggesting that maybe 60 millimeter Hg pressure from IPC might not be that effective for lymphedema itself, although it could potentially help with more general swelling or edema.
Interesting distinction.
Yeah. But overall, IKC devices seem to have a good safety record. Adverse events are pretty rare, mostly some discomfort or maybe skin irritation in some patients, especially at higher pressures. The chapter authors themselves actually recommend, when appropriate, using non-elastic graduated compression stockings, maybe those Velcro types, with a pressure of 60 to 70 millimeter Hg in addition to the standard CDT.
Okay, so potentially higher pressures with non-elastic options. We touched on this earlier, but let's talk a bit more about exercise. The book seems pretty clear that it's actually a good thing for lymphedema, debunking old myths.
Absolutely. Can't stress this enough. Contrary to that older advice, we now know that exercise can be really beneficial for people with lymphedema. It can improve your overall quality of life. It seems to help your body reabsorb that protein-rich fluid that builds up, and it helps keep the lymphatic system flowing.
How does it help flow?
Well, one mechanism is that when you breathe deeply during exercise, the pressure changes in your chest, decreased introthoracic pressure during inspiration, actually help to draw lymph fluid up from below the diaphragm. More breathing work, potentially better lymph flow.
Fascinating.
Plus, exercise can help with weight management, which we know is a risk factor, and that in turn can make it easier for lymph to drain. And as we mentioned, specifically, supervised resistance exercise has been shown repeatedly now to be safe and helpful for people with breast cancer-related lymphedema.
Great news. What about skin care and nail care? Those seem like common sense ways to avoid problems, but maybe crucial here.
They are absolutely essential, really basic but crucial stuff. Keeping the skin and nails meticulously clean helps to reduce the number of bacteria and fungi hanging out on the surface.
Right.
Using moisturizers, particularly ones that have a low pH, helps to prevent the skin from becoming too dry and cracking, because those cracks are perfect entry points for infection.
Makes sense.
And for arm lymphedema specifically, it's also a good idea to practice good hand hygiene, washing hands well, and keep the cuticles moisturized to prevent hangnails or little breaks around the nails.
Good practical tips. The book then outlines a therapeutic approach based on clinical stages. So how does the treatment plan change depending on how severe the lymphedema is? Does it get more intense?
Yes, exactly. While a comprehensive approach that includes general self-care measures applies to everyone at all stages, the intensity of the therapy definitely varies.
Okay.
Remember those two phases. The main goals of phase I, the intensive treatment, are to get the fluid moving and reduce any hardening or fibrosclerosis of the tissues. Phase II is all about maintaining and, hopefully, improving on those results long-term.
Right.
So for stage I lymphedema, that early stage with pitting edema that resolves with elevation phase I treatment might involve MLD perhaps once or twice a day, along with wearing the short stretch bandages. Then in phase II, you'd transition to maybe self-MLD and wearing compression garments during the day.
Okay, manageable.
For more advanced stages like stage 2, where the swelling doesn't resolve easily and fibrosis starts, and especially stage 3, where you get skin changes and significant fibrosis, the frequency and intensity of MLD and bandaging in phase I increase. People might need repeated rounds of phase I therapy over time, and in stage 3, surgical options might eventually be considered if conservative measures aren't enough.
So it really scales up with severity. That makes sense, tailoring the treatment. The chapter also discusses the level of evidence for these different therapies. What's the overall takeaway on what's proven versus maybe less certain?
Yeah, it's good to look at the evidence. The text concludes that CDT, complex decongestive therapy, when all its components are used together, is recommended for practice based on the research. It's the standard of care.
Okay.
However, the strength of the evidence varies for each individual part. Manual lymph drainage, MLD, on its own doesn't have strong evidence to support its effectiveness in reducing lymph volume, though it might help symptoms. Compression bandaging and compression garments, on the other hand, are recommended based on good evidence. They are key.
Okay.
The effectiveness of pneumatic compression, IPC, is considered less firmly established, maybe more as a supplemental therapy, as we discussed. Exercise is considered likely to be effective. And recommendations for skincare are primarily based on expert opinion and basic principles, rather than large-scale formal studies.
That's a helpful summary. We've been focusing heavily on the non-operative side of things, which is our main goal today, but the book does briefly touch on surgical treatment. What are the main types mentioned, just for context?
Sure, just briefly. The text mentions two main categories of surgical approaches. First are physiological interventions, which aim to actually improve lymphatic drainage. These include things like lymph node transplantation, moving healthy nodes to the affected area, and lymphovenous bypass, creating new connections between lymph vessels and veins.
Okay, rerouting the plumbing.
Kind of, yeah. The second category is excisional procedures, which involve removing excess tissue that's built up. Liposuction is one example, which has shown pretty good results in the upper extremity for reducing volume, though you still need compression afterwards. And then there's radical resection, basically cutting out large amounts of affected tissue, which is usually only considered as a last resort when other treatments haven't worked, because it can have higher morbidity, more complications.
Right, more invasive. And what about other treatments that might not have as much solid evidence behind them yet? Any experimental stuff?
Yeah, the book touches on several other therapies that have been explored, but where the evidence supporting them is generally limited or mixed.
Like what?
Well, medications like diuretics, water pills, and a drug called coumarin haven't really been shown to be helpful for lymphedema itself. Things like low-level laser therapy, hyperbaric oxygen therapy, HBO, which we mentioned that pilot study for, and intermittent negative pressure have shown some mixed results in studies and lack strong supporting data overall.
Okay. Anything on the horizon?
Looking to the future, there are some potentially promising areas of research. Gene therapy, using factors like VEGF-C to promote the growth of new lymph vessels, has shown promise in animal models.
Interesting.
There have been pilot studies on injections of steroids directly into the lymphatic system, autologous lymphocyte injections using the patient's own immune cells, and extracorporeal shockwave therapy. These have shown some potential benefits in small studies, but they're mostly still in the experimental stages, early days.
Right. Things to watch, perhaps. Unfortunately, even with the best management, there can be complications.
Yeah.
What are the main ones associated with lymphedema that people need to be aware of?
That's a really important point. The main complications are skin infections. That protein-rich fluid just sitting there in lymphedema creates a really favorable environment for bacteria and fungi to grow. This increases the risk of infections like lymphangitis, infection of the lymph vessels, erysipelas, and cellulitis, deeper skin infections. These can be quite common, maybe affecting 20–30% of patients, especially after lymph node removal for cancer. It's crucial to recognize and treat them early with antibiotics.
Okay, infection is a big one. Anything else?
Another, thankfully much rarer but very serious complication, is a type of cancer called lymphangiosarcoma. It's sometimes known as Stewart-Treves syndrome.
Cancer.
Yes. It's a malignancy that can develop in areas of very long-standing, chronic, often massive lymphedema. It originates from the lining of blood or lymphatic vessels. It's important for people with chronic lymphedema and their doctors to be aware of any unusual skin changes, like new bluish or purple spots or nodules. There are also other rare cancers sometimes reported, but the link isn't as clearly established.
Wow, okay. Scary, but important to know.
And finally, we shouldn't underestimate the psychological impact. Living with a chronic, incurable, and sometimes disabling condition like lymphedema can take a significant toll on mental health and quality of life. It can affect social interactions, physical function, body image, emotional well-being, leading to anxiety or depression. Effective management can definitely help improve quality of life, though.
Absolutely critical to consider the whole person. It's important to be aware of those potential challenges. The chapter also talks about the insurance role, which I can imagine is a major concern and source of frustration for people needing treatment.
Oh, absolutely. It's a huge issue.
Yeah.
While the book reports that most insurance plans technically do cover CDT, managed care often puts limits on the number of visits allowed per year or per authorization period.
Right.
Getting approval for more visits, even when clearly needed, can require a lot of paperwork and justification from the therapist and doctor. Coverage issues often come down to how severe the lymphedema is considered, even though we know unmanaged lymphedema can get progressively worse and lead to serious problems like those infections.
That seems short-sighted.
It can be. Unfortunately, some insurance companies still wrongly view lymphedema treatment, and especially the compression garments, which are essential for maintenance, as primarily cosmetic. This can lead to denials and the need for lengthy appeals.
That must be incredibly stressful for patients.
It really is. There's an important initiative called the Lymphedema Treatment Act that's been working for years to try and improve Medicare and consequently other insurance coverage for medically necessary compression supplies.
Ah, that's good to know about.
Currently, Medicare has a very complicated and often inadequate process for covering these garments: lengthy application, deductibles, copays, limited annual coverage, despite the fact that garments can be quite expensive and need regular replacement.
Yeah, we heard 3-6 months.
Exactly. Hopefully, research showing that using things like advanced pneumatic compression devices can actually reduce costly complications like cellulitis and hospitalizations will lead to better insurance reimbursement for this type of equipment, making it more accessible. There's some positive movement there.
Let's hope so. Finally, the book outlines what an ideal outpatient lymphedema clinic would look like. What are some of the key features of such a center? What should people look for?
Yeah, this gives a good picture. The ideal clinic would definitely take a team approach, bringing together various specialists as needed, maybe nursing, podiatry, dermatology, plastics, oncology, physical or occupational therapy, vascular specialists, even psychological support.
Multidisciplinary.
Exactly. Should probably be a member of the National Lymphedema Network, NLN, which is a great resource. It should have at least, say, 3 therapists who are certified by LANA, ideally including both PTs or OTs, and maybe someone with specialized wound care certification too.
Okay, certified staff.
Having access to a certified fitter for custom compression garments, may be available at least 1 day a week, and established relationships with reliable suppliers are also essential. You need to be able to get the right garments.
Makes sense.
The clinic needs to have a good stock of all the necessary CDT supplies on site: the padding, the different bandages, stockinettes, and importantly, the clinic should work to help patients overcome any financial barriers to getting treatment, like helping find resources for garments, maybe providing starter kits. They need to recognize patients often need 2 sets of garments, one to wear, one to wash.
Right, practicalities.
And the treatment rooms themselves need to be properly equipped, sink, no cupboard for hygiene, large enough for bigger patients, and have treatment tables that are safe and can handle higher weights. The NLN, through their Maryland Westbrook Garment Fund, is also a great resource the book mentions for patients who need help affording garments. And the text directs listeners to a table in the chapter with lists of helpful organizations and websites.
That's really helpful, painting a picture of comprehensive care. This has been an incredibly thorough look at the non-operative management of lymphedema. Just to bring it all together for our listener, the learner, what are a couple of key things they should really remember from this deep dive?
Okay, 2 main things, I think. Firstly, managing lymphedema without surgery is a comprehensive, ongoing effort. It's not just about treating the swelling once it's there, but it's critically about taking preventative steps if you're at risk and consistently looking after yourself with skincare, exercise, and compression as needed. Self-management is huge.
Right, proactive and consistent.
Exactly. And secondly, while complex decongestive therapy, CDT, with all its parts, is really the cornerstone for treating more advanced lymphedema, the different compression methods, bandaging, garments, maybe IPC, and appropriate exercise, play absolutely vital roles in managing the condition across all stages, from prevention to long-term maintenance.
Great summaries. And as we look to the future, what's a final provocative thought for you to mull over? Something to keep in mind.
Maybe think about the exciting potential of some of those emerging therapies we touched on, like gene therapy. Could they fundamentally change how we treat lymphedema, maybe even offer restorative options in the years to come?
Hope for the future.
Definitely. And also, maybe consider the ongoing critical need to advocate for better insurance coverage and wider access to specialized lymphedema care, so that everyone affected by this condition can actually get the timely, evidence-based, and affordable support they need for a better long-term outlook and quality of life.
Absolutely crucial points. If any of this discussion today has resonated with you, perhaps based on your own experiences or interests, we definitely encourage you to explore some of those resources mentioned, or, importantly, have a conversation with your own healthcare providers.